We have a pretty good, we're expecting a pretty good crowd today. So it's 1 o'clock and I see that we have about 30-ish people and it's climbing as people are joining us, but we'll get started because I know everybody's time is valuable. Welcome to CFHA Community Conversation, PCBH and CoCM, and how providers working within these models can provide optimal care. I'm Tanya Lauder. I'm one of the facilitators of this program. I'm actually CFHA staff, the business manager and engagement manager. We're excited about this new offering from CFHA. We've had a couple really great conversations about other topics, and I think today's conversation is going to be wonderful as well. So I'm going to turn it over to my co-facilitator, Corey Knight, who's going to introduce a few folks to get us moving forward and rolling with this conversation.
Thanks, Tanya. Hello, everyone. Good morning, good afternoon, wherever you are around the continental United States or otherwise. So my name is Corey Knight. I'm the co-facilitator. Just to give you a little background, I'm a second-year doctoral student at the University of Houston Clear Lake. Background training, completed graduate certificate in integrated behavioral health care. So I'm really passionate about the topic. And we appreciate you all joining with us today. This is an ongoing, evolving thing, but really what this is about is the community. And really, this is to have just an active dialogue and hear everyone's voices. And this is an evolving, really fantastic opportunity. So thank you all for joining. So today, what we wanted to focus on is something we noticed in the listserv. And that's really this discussion that's coming up about the PCBH model, the collaborative care model, how these models are similar, different, and really what this boils down to is, how can we provide the most optimal care for the patients that we see? And so, today we have a few presenters. So I see Eric as of right now. Eric is someone who has a ton of experience with the CoCM model. Has started many clinics, built the practices up. It's a really great super contributor. So I'm grateful for you to join us today, Eric.
Thanks for having me.
Yeah, thank you. And so, just to kind of get the ball rolling, we do have a couple other contributors, super contributors as well. As we get to the questions, I'll see if they pop up. But, first things first, we'll go ahead and jump in. So let me go ahead and get to the slide. And so really what I want to do is just start off with some basic talking points. And really what this focuses on is first off addressing that, in the literature, the terms PCBH and CoCM sometimes are used interchangeably as behavioral health. And I think for some providers, that just does create some confusion. And so what we'll start off doing is just talking a little bit about defining really what the PCBH model is. And then Eric, I'll turn it over to you to talk about CoCM as well.
Okay.
So first off, I'll go ahead and jump in with PCBH. That's probably the model most of the attendees are familiar with. And really what that focuses on is, the same day access, the flexibility, really thinking about providing patient-centered care as part of the healthcare team, brief behavioral interventions, evaluation, really almost being a jack of all trades, and really being able to provide as much support as you can for the care team. And this really rose out of a historical need, for medical providers and others who were struggling with patients at times, and this evolved from, I would say, like grassroots efforts to this really wonderful model that many of us use these days. And so I would like to, this is always the fun with doing share screen. I would like to, turn it over to Eric a little bit, just to hear more about CoCM, his experience with it, and then we'll open the floor up to others as well.
Well, again, thank you for having us. My knowledge base is squarely centered in the world of CoCM. Just a little bit of background to build some context. I am not a clinician, nor do I have a long history in the behavioral health spectrum. What I do have is a passion for expanding access to behavioral health services within the communities we serve. I have a personal story related to my family and the need for these services and the complexities of achieving them. And that's really what drove me back in 2017 to begin looking at different ways to integrate these services in primary care. And it became a passion project, which ultimately became an organization. Today, Evolved MD operates in Arizona, Utah, and soon to be Colorado. We have 23 individual sites established across those geographies, all fully integrated CoCM models with providers on site, providing patients with services either face-to-face or through a virtual or telephonic solution. So a little bit of background about us and the history there. We now are moving forward. We have in excess of 100 sites on the docket for the next 18 months. So we've got some exciting growth ahead. Now, specific to my view on integration, I would tell you I'm model agnostic. I believe it's the end goal. It's just a function of how you get there. But I'm also a pragmatist, and a lot of the way that we deliver these services is based upon the manner in which we can get reimbursed to ensure that these programs are sustainable both from a clinical and an economic model. So specific to CoCM, traditionally, I assume everybody on this call has read the literature from the AIMS Center. This is a team-based approach, well validated both from a mental health and a physical health perspective to provide us with some value, both on the clinical and an economic side. Within our model, we have a primary care provider who is acting as the managing provider. On site, we have what we call a behavioral health manager that assesses patients, develops care plans, provides brief interventions. And then we have a psychiatric consultant who is a team member, provides weekly caseload reviews, recommendations on care planning, medications, and other. And then this is all tied together for us with a cloud-based registry system that we built, and it's designed to stand on top of the EHR system and allows us to push and pull data between the systems. So at a very high level, when you look at the way we view psychiatric collaborative care, or CoCM, it is in a very traditional mode, and again, based upon the research and the data provided by the AIMS Center. Where we deviate and where we have a lot of alignment with the PCBH crowd is that we do not view an integration solution as being simply designed to address the needs of mild to moderate patients. We view that a comprehensive solution should provide our physician partners with a solution to send all patients to, regardless of need and regardless of acuity. And so within our model, we take all comers. If a patient has a behavioral health disorder, we will enroll them into the program. And based upon their need, if they're mild to moderate, we will manage them in-house with our clinicians, developing care plans, providing brief interventions, working with our site consultant to manage medications that are ultimately prescribed and then managed by the PCP. For our higher acuity patients, we will also enroll them into the program. We will determine their needs based upon their acuity level and their diagnoses. And then we will take off, call it our therapeutic or our counselor or therapist hat. We'll put on our case management hat. And although we will do care planning, we'll provide brief interventions, really our focus for these patients is more on how do I coordinate with providers in the community to get to them to the appropriate level of care and ensure that they have the highest probability of finding a provider, getting to their first visit, getting care, and then ultimately closing the loop on that service delivery and ensuring that our primary care providers are updated in the loop. So at a very high level, I think when you look at CoCM as a whole, our organization is delivering something that's probably highly aligned with what the PCBH community does. It's a hybrid of sorts, but we do in fact render under CoCM, and we bill psychiatric collaborative care codes.
Yeah, thanks for that, Eric. And so, yeah, I mean, what it sounds like is there's that stepped care approach and intervening early, trying to match patients with the appropriate level of intervention, and then building from there, essentially. And I think that's really one of the biggest benefits of, PCBH, CoCM, and the integration of these models is connecting the two together and seeing them in kind of this complementary manner. And so I see I have a question here from Rano about the essential difference between the two models. And so, Eric, I think you gave a great description of the CoCM model. And so what I want to do is we have a couple other super contributors here as well. And so I have Allison and then I have Noel. And I just saw y'all both on here. And so I know Allison has a lot of experience with the PCBH model. And then Noel has experience working within both models in a very complementary way. And so Allison, if you're there, if you want to chime in and talk just a little bit about your PCBH experience, and then Noel, I'd love to hear about your experience as well with both.
Yeah, can you guys see and hear me?
We can.
Perfect. And I know Cody's been able to join too from the PCBH, so from CFHA. So anything, Cody, you have
Great.
to add, please don't hesitate to jump in. Eric, I just so appreciated your perspective on this, because being really more in the PCBH model here in my current position and having a lot of people come to us with questions about CoCM, we have really landed in a camp that you're talking about, which is they're not contradictory models. We're all just trying to get the same goals and outcomes for patients. It's kind of how do we get there? What's the end goal? And then what pieces of each model, or kind of an interconnect or an integration, because we love that word in PCBH, of that those models can we use to get there? And so I really appreciated that perspective. And I'm excited to hear from Noel about how they've done that, because I think that that may be where a lot of us end up in the future. So from sort of the PCBH perspective, we are really working to provide care in the moment that is needed by patients who are presenting most commonly in primary care. So oftentimes it is behavioral health consultants. And so typically those are more your therapists, psychologists who are providing in the moment behavioral health care in the moment for primary care needs. Less so on the psychiatry end of things for PCBH historically. And so I think that one of the things that PCBH has historically talked about are those more mild to moderate or subclinical symptoms. However, I would say the reality of it is that we see the entire gamut and spectrum. So I think the initial literature really talked about that. However, I don't really know that that's how it pans out. That's certainly not in our practices how that looks. And I just don't think that that's the reality for most of us working here either. Cody, anything that you would add kind of from your perspective on PCBH specifically?
No, I think you nailed it. You know, from the perspective of just kind of the whole gamut of care, from prevention to treatment, I think is a big component of it. Just not having specific conditions that are targeted, just that full gamut, full age range. In the moment, as a team, real-time decision-making as a team together in the moment. And then, yeah, I think the psychiatry component is something that's been integrated in a lot of different areas in a lot of really creative and unique ways. But hasn't been completely defined, I think, in the models yet, and how that partnership happens explicitly, which is one thing I'm excited to hear about here.
Yeah, I mean, y'all brought up you brought up a ton of really great points. And I see in the comment box too that Amy Jones had talked about, exactly what you were saying, Allison, the subclinical. And I think in the reality of it is when you work within this model, it's not subclinical. This is an all-comers approach. We take everything and anything. And honestly, all patients can benefit in some way. I think the focus, as both of you are saying too, is that how can we really do the most good with the resources we have and the time we have, and I think that's why this kind of stepped care approach between, mild to moderate to everything, and then working with like a psychiatric consultation liaison type of system is so essential. I mean, it's so necessary. So Noel, what I'll do is I'll turn it over to you and I'd love to hear about some of your experience working within both models.
Okay. So I'll give you a little bit of my background. So I started with integrated care in PCBH. So I actually was doing psychological testing for 5 years and then fell into PCBH. I was kind of in a place where I'm like, I don't know where I fit in the world of psychology. I don't want to do long-term therapy. Really don't want to do testing anymore. And I fell into PCBH and never looked back. I loved it. And then I moved to an organization to more of a clinical manager and inherited a team that is doing collaborative care, but was also tasked with starting integrated care in pediatrics, which we're doing in a PCBH model. I think the interesting thing about our collaborative care is, so the psychiatry piece of it had been going on for a while in our organization, but the behavioral health providers, we call our folks behavioral health providers, they were actually doing more co-located care. And then in October of 2019, they brought the AIMS team in, gave them some training and said, okay, we're going to move over to collaborative care. And then in March of 2020, everyone went home to work from home because of COVID. And so it was really difficult to have an entire team switch what they were doing from home. And COVID presented its own challenges of like level of care and level of need. And we're in Spokane, Washington. So we have a lot of resources in the community, but as the rest of the country, right now, all our resources are full, and we are as well. We opened an outpatient clinic, and we have 3 providers, and we filled it within 30 days, and we have a 100% wait list. So like, that's what, you all know, that's what behavioral health looks like. So right now we're kind of in the beginning stages of blending these 2 models. And when they started the collaborative care here, it actually is, like, the longer I've sat with it, it is more of a mix of the model, right? So we have on the collaborative care side, we have the psychiatric prescribers, we call them psychiatric consultants. Our BHPs are very much like the care managers. But then there's also this piece of they're doing warm handoffs as well in a very kind of PCBH way. So they have their registry, they have their folks that they're seeing every other week for half an hour, but also have kind of weaved in, and it's been bumpy, and we're still figuring out like how to level set so we can do both, right? Because if you have a full caseload and you're seeing, those, not a caseload, but if you have a full schedule and you're seeing 8 to 10 people that you have scheduled a day, how do you take a warm handoff? How are you available to PCPs? So for us, we're really, now that everyone's back in clinic, trying to scaffold out and figure out what pieces of PCBH and what pieces of CoCM work for us in our organization. On the PED side, we are not using CoCM much. I mean, we have a child psychiatrist, but we're not doing it in the same model as CoCM. We are really doing a little more PCBH, but in my experience of PCBH has never been, we're just doing subclinical stuff. I was the only therapist in a clinic here in Spokane. And so I saw everybody. And if it was complicated and they need long-term care, then we got them out to the community. But I was still seeing, people with PHQ-9s of 25 because things were going on in their life. I think we all are, especially in the pandemic. I think the pandemic has revealed for us how PCBH can be so much more than just grief or subclinical stuff. I mean, it is parenting skills, it is grief, it is subclinical, but we can do some really great work for folks who maybe don't want to dig down deep into that trauma, but want to relieve some of their depression and anxiety symptoms and want to be more functional in their life. And so we're in the process of just marrying this. So that's why this conversation was so exciting to me, because I was like, oh, we're in the middle of doing this. Like, we need to put our heads together and talk about what this looks like, because I really do believe there's not a firm boundary between the two. I think it's clinic dependent, it's population dependent, and we take what works for us right here.
Wow, Noelle, yeah, you've had quite the journey with that, and it's, yeah, I think you hit on several points that I think are important to just kind of flesh out. Is that within this model, it sounds like there's a lot of trial and error, and figuring out how best to combine these models. It's almost exploratory, probably just like the early origins of PCBH were, you know, but also too, you know, the adaptability, it seems like fits well with both models because you can find a way to make things work and make things integrate. And it's not always going to go smooth, but I think that's the benefit of trying this and then tracking the outcomes and really seeing how they complement each other and, you know, but in providing the best patient-centered care you can. You know, so I'm excited to continue to hear about that too, because I think again, this is probably the future. And this as Allison kind of pointed out too, and Cody as well, this is where it's going. You know, and Eric, I mean, to hear the tremendous growth on your side too, you know, I mean, this is a powerful movement. You know, in looking at the chat box, I'm seeing a couple things pop up too. And so I saw a couple comments people had about the PCBH and CoCM. It looks like referring out, primarily referring out. And that's not so much been my experience. My experience has been that, you know, referring people out does not generally go well. And the literature reflects that as well. And most community mental health services are already overburdened with high wait lists. And so, you know, that's something, and I'm seeing some head nods there as well. So I know we do our best to provide services in-house, just, you know, to be accessible and, you know, provide the best care we can. You know, and something else too, another theme that I saw popping up was, I guess, talking about funding, which I know is always a fun issue to discuss within these models. And I don't know if y'all can, I guess, Eric, because I see you're unmuted right now, could you briefly talk about funding with this model?
Yeah. So I think the first thing I'll say, and I think this consensus is building on this call, you know, PCBH and CoCM, they have more similarities than differences. And the future of behavioral health integration isn't one or the other. It is a combination of both. And it's just dependent upon what the needs of your practice are and the needs of your patient. So this notion of reading academic literature on one model or the other and saying this is going to work, you're probably setting yourself up for failure, because you need to look at the variables specific to your practice, specific to your population. And the fact of the matter is it's a combination of both. And so before I get into funding, I want to hit on the acuity piece. And the pandemic blew this wide open. When the pandemic hit, all of us that were integrating saw our community-based resources evaporate almost overnight. And it forced us to rethink the way that we manage patients in the community. And the fact of the matter is that we have to manage higher acuity patients because they have no other option. And so when you're building your model, you have to accommodate for that because it is here to stay. We don't have enough community-based resources. And when we do use those resources, we need to be mindful and efficient about sending the right patients at the right time. Now, coming full circle to the funding piece, this is the other reality and the other variable that we all have to consider. You know, I assume we have some traditional fee-for-service primary care sites here. I assume we have some academic medical centers. I assume we have some FQHCs. All of these groups have different funding mechanisms and different considerations. And so that will also guide your path on which program to choose, how it's funded, and how it's paid. What I will tell you definitively today is that if you are in a fee-for-service world, there is only one option economically that is going to address the sustainability component from an economic perspective, and that is the CoCM model. There are established codes. Most of the national commercial insurers are now covering those. Medicare Advantage plans are covering those. And right now today, I believe there are 22 states with Medicaid coverage also supporting those codes. We are very bullish on the notion that 22 states is going to expand to 32 and 42 and hopefully 50 in the near term. And the example I will give you to gauge my confidence is the state of Texas. Texas was always going to be the holdout in our mind. They were going to be the last to come to the table. And they announced that these codes will go live in September of this year. So if Texas, that has a very interesting Medicaid model, is going to adopt these codes, I think we can assume that other states that are on the sidelines will follow. And so the thing from a funding mechanism that you guys have to understand, and we all have to understand, which is, how am I going to get paid to sustain this program? Am I in a fee-for-service world? Then if that's the case, CoCM is the most likely. if I have grant funding or other funding from the institution I'm at, or if I'm an SQHC, I probably have a lot more options, whether it's PCBH, CoCM, or other. So, really funding is one of the first variables you're going to need to consider. And based upon your environment, you guys can back into a model and get creative with PCBH or CoCM or a hybrid between the two.
Yeah, I mean, you definitely gave a lot to process there, Eric. I mean, there's definitely, I can see the movement in that. I'm in Texas right now. And so I've seen some of the stuff popping up on listservs and, from what you can see from the state legislature here. And I think one of the biggest challenges is helping individuals in those positions to understand the benefit of still incorporating brief interventions into the model, because that's, we could probably talk about this all day, but I think that's one of the biggest challenges is the, thinking about that step level of care. And unfortunately, there's not enough education out there about it, especially within a behavioral health context. So I think you really bring up some strong points. And, Allison and Noel, I'd love to turn it over to either of y'all and I guess hear, your perspective on that or your experience with that.
Yeah, I think that there's a lot of different considerations to put into place. I will say I had a bit of a response to the idea that like CoCM is the only one that's financially viable, or only CoCM only is financially viable. And maybe that's because I'm in the PCBH world. And I think that this is kind of where the rub comes out, right? Because it is whenever I just had this experience in my own health system, actually, where we had an outside entity, so an organization that when they came to our facility and saying, hey, we can offer you a prepackaged CoCM, would you like to take it? Knowing that we have PCBH, but we're part of like a hospital group, that was part of what was offered. And our hospital turned it down because they had their own financial people take a look at it, and it wasn't quite as viable as was initially said. And so I think that there are nuances to this, and maybe exactly what's being sold, and also the viability of PCBH, I think, is there. We have to get creative with it, as we have always. But I do think we do. And I just want to really highlight what Corey said, which is there is a place for that immediate brief intervention and the prevention that PCBH provides that hopefully prevents patients from needing that higher level of care, right? And so when we think of these stepwise cares, I don't want to discount one of the steps, which I think that we're a big foundation of that in PCBH. And so I think marrying the two, and that's one of the things that we've talked about here, like what helps make us more financially sustainable over time, is that a marriage between PCBH and CoCM and a few other things, actually, not just one of those two things. But I think that it's how you set up and future-proof, I'm stealing Cody's wording here from other conversations, how you set up and future-proof for your financial viability in your model. And that is going to be, as Eric very aptly said, dependent on like the organization that you're in and the organizational goals that they have. So what outcomes are they looking for? And is that only financial? Or are there other outcomes that they are willing to take in, like cost savings, to demonstrate your sustainability over time? And I think that that is a real strength that PCBH shows too. And hopefully that the marriage of those can help level set, or that's the proposal that I'm making here at Gunderson, is how do we use all of these things to kind of offer a myriad of services and level set, balance that out so that our patients get the best of all of these worlds that can be offered to them. I'd love to hear, Noel, kind of how you all are doing that. That's very exciting for me.
I have no idea. I don't have a lot of hand in the financial piece of this. I know on the CoCM side, like they pay for, they bill, they diagnose. Our billing people get pretty creative and have made that work. And so it's interesting to see. I'm not exactly sure what it's going to look like on the pediatric, more PCBH side. We're actually just kind of learning from each other. Like the billing people are learning about behavioral health and I'm learning about billing. And so at this point, we're kind of just figuring it out. So I wish I had a really good answer. My sales pitch is that some of the PCBH stuff pays for itself in the time that we save providers. So your providers can have 15 or 20-minute visits, because when they get doorknobbed by, oh, and by the way, I have had that suicidal feelings and depression, they could be like, oh, I have someone for you to talk to. And they're not running late, then patients aren't dissatisfied because they're, running 30 or 45 minutes late because they're handling this crisis. Like in many ways, that's my sell for those non-billable visits, right?
Yeah, I mean, and I'm as I'm hearing all of y'all talk about this, and again, this is not a simple answer. It's not. In an ideal world, we would have the ability to where behavioral health consultants would be readily available, services would be able to be delivered the same day. This would be a standard part of whole person care. And the reality of it is navigating these pitfalls can be very, very challenging. And I've noticed, I've been watching the chat too, because I mean it's alive with conversation, and I love seeing this. I love seeing the dialogue that's going, because a few people have acknowledged as well, like this can be a hard area to talk about, because we're trying to, I guess, meet in the middle here in certain ways. And other ways, some of us come from a stronger PCBH background, and so we want to advocate for that model, and I think something that we're all hitting on too is like there's a place for both, and I think that's the hard part is the paradigm shift is tough. It's really, really tough, and just looking through here, I did see one person had emailed me, Amy, or sent a message. Amy, I did want to chime in because she had a little bit of info about financial with, I guess, some of the system in New York. So Amy, I don't know if you'd be willing to speak up for a minute and just talk a little bit about that, and then we'll move on.
Can you hear me?
Yes.
So sorry, working from home. I'm not camera ready today, but I'm happy to chat. So my name's Amy Jones. I'm the Director for Primary Care and Behavioral Health Integration for the New York State Office of Mental Health. We've been actively supporting the implementation of collaborative care in primary care physical health practices since 2015, and are proud to have been the first state, as Eric pointed out, it's now grown, but the first state to create a Medicaid reimbursement system for collaborative care that predated the Medicare final rules in 2018. So we've been living in the finance realm of this for quite some time. We also do a lot of very hands-on technical assistance and training to support adoption, implementation, and sustainability, and currently have about 350 primary care practices that are actively providing collaborative care. And we do collect some data from them to demonstrate process and outcomes as well. So I think the financial piece, I've tried a couple times in the chat. I'm happy to answer any specific questions folks have. I think the financial sustainability is a challenge, and I appreciated that. That was one of the first comments that Eric made. For us, I think a best practice or a service to patients is only as good as it's going to continue to exist. And unfortunately, in our current space, that means that providers have to find a way to pay for it. And I know at least our system in New York still relies pretty heavily on fee-for-service reimbursement. So thanks again, Eric, for making that clarification. I think we're always hoping to move towards a more value-based system, but right now we're kind of in this purgatory between the two, and that makes it hard to take some more risk that a fully value-based system would allow us to do. So, we do find that collaborative care, when done optimally, can be financially sustainable. We are fortunate in this state to have reimbursement in Medicare, commercial, and Medicaid. So all payers, all populations across the board. And that definitely has helped. And in our experience, I think we would love to be able to support more PCBH. But since what I was commenting on in the chat was about that kind of subclinical, collaborative care claims, both on state and federal levels, are based on having a behavioral health diagnosis. And although that can care that still have behavioral needs. So that's why I was commenting that sometimes that PCBH model can be a little bit more challenging. I think another consideration is also in the licensure or training of the person that you hire to be your behavioral health care manager for CoCM or your BHC for the PCBH model, because there are various restrictions based on your state and federal regulations or what commercial plans will allow to bill and based on the level of licensure that a person has. So for example, in New York, you may need an LCSWR to bill for some psychotherapy services. And, in PCBH, if you're not relying on billing, if you are able to do it more from a value-based perspective or through CoCM, even because the billing is under the primary care provider, not the IDs of that individual behavioral health provider, you may have a little bit more flexibility in who you are able to hire, which may allow you to optimize workforce challenges and shortages a little bit more. So there's certainly a lot of considerations on that front too that I would suggest. And one other thing I would just encourage people to think about that we really appreciate about the collaborative care model, especially from kind of a state payer and plan perspective, is that CoCM focuses on this treatment to target approach and really is data driven to be able to use quantitative figures for outcomes for behavioral health. And I think that that's something that's really unique in the field of behavioral health and community mental health. Sometimes they don't even use a PHQ-9, and an assessment of a patient improving is pretty subjective often. So really having that and being able to efficiently address challenges for patients if they aren't improving to treatment protocols and things based on having that quantitative data, I think has been really helpful too. So that's something I would suggest people think about as they integrate these programs. But yeah, I think it's challenging because it's so state specific, but I would love to be able to see PCBH be more financially sustainable in this world that we're living in. So hopefully we can get there.
Yeah, I mean, Amy, mentioning all that, it does. I mean, it sounds like there's a lot of challenges with that, and that runs state by state. I mean, states have very different policies and rules, especially with the licensing and the reimbursement of behavioral health providers. We run into a lot of challenges with that. I mean, I know myself, like here in Texas, we've dealt a lot with the integration of like licensed professional counselors, LMFTs, social workers, psychologists. There's just a lot of back and forth with that. So I would imagine, I mean, the billing is again a forefront issue. And and I'm looking at the chat as it's going, and I mean, this could be a conversation in and of itself. I mean, easily, because I notice a lot of people, there's different approaches, their clinics have done different things, but I mean, I thank you again for that, because I think this is helping give a balanced perspective. And I think really at the end of the day, that's what we want with this. We want to kind of hear from both sides of how these models are and how they work. So again, thank you for your contribution with that. And I also want to thank everyone in the chat box is very much alive in this conversation. So I want to thank everyone so far for that, and also our super contributors as well. I see y'all adding in too. And so for the sake
I'll pop my email address in the chat too. So if anybody has any questions about finance stuff or whatever with CoCM, feel free to send me a note. I'm available.
Perfect. Thank you, Amy. So I'm going to go ahead and jump to the second question, because I think this is an important point as well. Again, we've touched on, there seems to be room for both models. So again, thinking about the goals of the model, how would you say maybe they differ for the PCBH model as compared to the CoCM model? How might they be the same? And I'll go ahead and so I think Allison, I saw you on there. So if you want to go ahead and jump in from the PCBH perspective, I think that would be great. And Cody as well, I welcome your contributions too.
Sure, I have to find the unmute button each time. So I think for the PCBH model, there's a few different goals and some that have really been backed by research with outcomes for PCBH that I think are important to mention, and ones that we, in our organization recently took to bat whenever there was the idea of, should we be switching over to CoCM, or should this be some kind of a mix? So one of them I think is definitely PCP satisfaction. And so that's one that really holds up in the literature for PCBH. So primary care provider satisfaction, both with the model, with the service, and increasing their satisfaction and efficiencies at work. Access to care is another one that really holds up for primary care behavioral health. Patient satisfaction. There's some good literature for diagnosis specific outcomes. So depending on what diagnosis you're looking at, I know Amy, you mentioned specific measures of improvement. Those are similar measures that we are using in PCBH and some others regarding functionality and improvements. So with regards to weight, tobacco use, sleep symptoms, PTSD, anxiety, depression, and then functioning are some that come off the top of my head for the PCBH model. More efficient use of PCP time, and then decrease in cost through both prevention and early intervention. So those are kind of the primary ones that come up for me whenever I think of outcomes and goals for PCBH. I don't necessarily think that there's such a rift between two completely separate goals. So I do want to put that out there. I don't think like CoCM has a whole nother host and list of goals that is totally different. I actually think the goals of both models have a lot of overlap in them. And that's one of the things that we had a big conversation about is, yes, these are goals for PCBH, and CoCM has some of the similar ones. And I think patient treatment is certainly one of them, right? So improvement in those symptoms and intervention for care. Cody, anything you'd add for the PCBH side as far as kind of goals or outcomes? Oh, we might have lost him. Or he's frozen.
I think he's frozen. So
that's okay.
Another delightful benefit of Zoom.
He can add it to the chat if he thinks of something I missed.
Sure thing. Well, so I mean, and that you bring up a great point, Allison. I mean, the evaluation and assessment component, the data-driven outcomes. I mean, we still use a tremendous amount of that within the model. And I know for reimbursement purposes, that's an essential component. We need trackable outcomes. We need to see that people are improving in some way. And so I know just based off my experience and working within an integrated care setting, that was crucial, and I think that the community and mental health movement as well is people are starting to have to embrace that if they want to get reimbursed. They have to, so these days, which I think is a step in the right direction personally, is these days of, just saying, okay, well, I'm glad you're feeling better based off what you're saying. That's just part of the data. We need quantitative measures. We need qualitative measures. I mean, it's part of the bigger picture. So thank you for that, Allison. Eric, I'd love to hear your opinion on that.
I wish I could dispute Allison. I think this is the great thing about this conversation. You outline the goals and objectives of PCBH, and then you overlay it with CoCM. They're the same. We're trying to expand access. We're all trying to do that. We're trying to drive better outcomes, both clinically and economically. We're trying to ensure that the patients and the providers are satisfied, and these are things that we're probably all measuring and probably getting really good results. The providers love integration at whatever level. And so they're not that disparate. I mean, I think how you get to that end goal is slightly different, but we have more commonalities than differences. And I think this conversation is really good because my perception of the CoCM world and the PCBH world is we're both kind of doing our own thing, and there's not a lot of middle ground. And I think what this call is highlighting is, man, there's a lot more middle ground than there is differing of opinions. And so we're both trying to get to the end game. And again, there's some variables. I'll let the academics on this call evaluate the data and do comparative research in the future. I'm probably more of a business operator or the business guy, which says, we just got to figure out how to get the patients these services, and whether it's PCBH or CoCM, I don't really care as long as the patients get what they need and we can make this program sustainable through whatever funding structure we have. And so for our world, it's the CoCM is a good fit. But again, I think there needs to be flexibility from the payers, and then how our community approaches this, because it's not one or the other. It's a combination of both. So I know that's a bit of a political response, but that's the fact.
I think one of the things that I appreciated about that, Eric, was how it does involve both. I think the other piece that I would just add, Cody sent me a message, he got logged off, but that he brought up, which I thought was a really good point for the PCBH side, is that we also are looking at overall health. So not just mental health diagnoses. And I think that that is it's a good adjunct or a good additional piece that PCBH brings to it. And when I think of that for like HBAI codes that we're billing or those kinds of sides of things, I think that is important to bring to the table, that sometimes we are seeing patients that our goal is just helping with their overall health, diabetes management, smoking cessation, those types of things. And I don't know that we've really layered that piece in the conversation yet. So I just didn't want to miss that gem. Can't claim it, it's from Cody, but wanted to add it to the conversation.
Yeah, I mean, thank you, Allison. And yeah, I agree with a lot of what you said, Eric, in that this is the benefit of these conversations, is that you may get a mix of consensus, but the thing is we need to have people who utilize both sides, and we need to understand like how these two things meet in the middle. Because at the end of the day, kind of what you touched on, Allison, you've touched on, Noelle, you've touched on, I mean, many of the people on this call, it's about providing good patient-centered care. That's our end goal, is provide the best care possible. And so sometimes we got to have hard conversations. Sometimes we have to, make ourselves uncomfortable with this and be vulnerable to really understand how we can best operate and how we can have the greatest impact. Noelle, I'd love to hear also from you, because of your unique experience as well.
I think it's been interesting. And I think my director would tell you that when I first came here, I was like, COCM, PCBH is the way to go. Right. And I didn't know about COCM, right? All I heard was the chitter and chatter of like one versus the other. And then I was forced to learn CoCM and delve into AIMS and do all that stuff. And I think that's kind of the beauty of being able to marry a little bit of it. Like on the one hand, at first I was like, oh, a registry, it's so cumbersome. And now I'm like, oh yeah, a registry, like I can now track PHQ scores very easily. I can keep an eye on who's getting better and who's not getting better over a period of time, that maybe they do need a higher level of care. And so I think there are pieces from both that are just so beautiful. And I think from a perspective on the ground, because I still am in the clinics, particularly this time, I hate to use the word unparalleled because it's so overused when we talk about COVID, but particularly this time, like as providers, this is hard. This is a really hard time to be in mental health. I was speaking to a child psychiatrist the other day, and we joked, and my joke was like, you would be hard pressed to find a mental health professional right now that isn't burnout. And if they are, I want to know what they're putting in their margaritas. Her response was probably clonazepam. But I mean, we're all burnout. And so I think one of the things that PCBH brings to the CoCM side that we could utilize are some of those grief or smoking cessations or grief or preventative stuff, right? Isn't it so great in a day where, in my background at PCBH, we do have fewer visits, so we're more available, but wouldn't it be great in a day where you have 6-7 clients on your schedule to know that with one, you're just working on some smoking cessation, and it's not trauma, and it's not, severe depression, and it's not, dealing with a housing crisis. Like, I think that's where I think it could kind of be beautiful to meld the models together in a way that works for the clinic. And so that has been, for me, the really exciting piece of kind of being in this place where I started 3 months ago, to be honest. And so I always say, like, someone told me, 18 to 24 months before things really get rolling. And I, like, day one for me is the day I started, because that's when we really started having this conversation. And so it's really exciting to literally be kind of birthing this program in an area that is pretty densely populated comparatively to other places, and doesn't have a lot of this. So it's kind of cool to be doing this. And that's why I was so excited when this topic popped up on the listserv and was like, yes, please, let's talk about this because this is hard.
Yeah, I mean, so Noelle, just to, give a little plug, our last call was really talking about how providers have dealt with the pandemic and how providers have dealt with the shift, and it really touched, I think, in a lot of ways on how we've all collectively been struggling and doing our best to maintain some sense of sanity, but also be there for others and be supportive and provide the best care we can, and that's, I think your experience really shows that you've had to wear multiple hats, adapting to this big change, adapting to the pandemic, still keeping yourself afloat too, and I think that's something that a lot of us have had to do, over the last year and a half in a lot of ways. And I think that really touches on just the strength that we as providers bring to this, and that I think transfers over in a lot of ways. And just hearing the dialogue that we've had and seeing the conversation, yeah. And Monica, you just brought up a good point. I'm looking at the dialogue. I'm looking at four things right now as we're going through, but also supporting our primary care team, and again, that's one of the benefits that we bring to this model as well as BHCs. But all of this dialogue is really hit on the third point already, which is really how do these models come together? And I think all of our super presenters have really touched on that, really how these models come together. And I think this is a continuing conversation, really understanding more and more how we can integrate these two models and how they benefit each other, and so all of y'all's contributions have been really great so far, and I really appreciate that. And I know I'm trying to keep an eye on the times. I know people are, taking their lunch break and, whatever time they can fit in a busy day, but I really appreciate the contribution of everyone. And what I'd like to do probably for like the last, because I think we have a little around 10 minutes, is I would like to just kind of open the floor for anyone who, may have a question or an observation, that it's just been burning this time and really would like to get some more clarity. So I'm going to mute myself. If someone wants to chime in, please do.
I can jump in quickly to just say that we've thought a lot about this and how to integrate it, and we're trying here at Nationwide Children's Hospital, as well as through Partners for Kids, which is our partnership ACO, to really think about how do we maximize the best of both, right? So we have a PCBH model that provides highly integrated care, doing the therapy work. Our psychiatrists don't want to be supervising people doing therapy when there's so many kids and doctors who need medical consultation, right? And so we're really trying to free everybody up to work to the top of their abilities and to do the things that they're most expert at. And so psychologists are doing integrated psychiatrists, are partnering with our physicians to provide medication consultation through telephonic consult lines. And we have a program here called BH Tips, which is basically open office hours for psychiatrists. They take 4 hours every day where they have 15-minute consults where any pediatrician in the community can log in and schedule a 15-minute consultation. And so we're really focusing on who's expert at what. And psychologists and social workers and LMFTs, they're experts in doing therapy. And so we're really trying to hit that hard within our primary care offices and doing that team-based care. Psychiatrists are really expert in that medication piece and something that we're not as expert in. So they're really hitting the medication pathways really hard. And, borrowing from some of the CoCM, having registries developed and explicit care pathways for the folks who are clinical, but also having the PCBH as a support model for those who aren't clinical or a subclinical or don't need that level of intensity of service or just aren't ready for that level of intensity of service. So that's kind of how we've been trying to integrate both, is just to think about where are we uniquely expert and how can we best benefit the system and the patients based on those expertise. And
I think we lost you again, Cody, but I think Cody really touched on some great points, and how, psychiatrists, behavioral health behavioral health clinicians, how we can fit together and how we can benefit each other. And again, really at the end of the day, providing the best care we can. Let's see, anyone else?
I would also just add that I know we've talked a lot about like financial viability and sustainability. I think another piece to think about in determining which or combination or how you might set this up in your own organization would be what personnel resources do you have? So that isn't something that we've really talked about, but it is something that's really important. And so do you have psychiatry access to make some of these other pieces happen? Do you have the access that you need to the right credentialed providers to do PCBH? I think that those are really important pieces in regards to capacity can you in fact make this happen? And I know that's something that we've really thought about here with what we're offering. We kind of have an array like Cody's talking about, and we're talking about is CoCM going to be a potential part of that array for us, or what part of that are we doing? And the other piece that I would just add is I think that lots of us are doing sort of a blur already without necessarily knowing it. And so when I think of CoCM, I think of registries and people with diagnoses. We're doing lots of pieces of that. We're not billing those codes, but we're doing automatic shared cares for specific things, automatic warm handoffs for specific things. We are following registries and scores for patients. And so I think that we have built in, probably unknowingly, right, at least initially, some of those pieces of that model that knowing more about it and learning more about it would really benefit our patients. Like Corey alluded to, our goal is just to take the best care of patients we can in the most sustainable way we can with the resources that we have.
I would follow up Allison on that. Like my introduction to PCBH was we tracked PHQ scores and we had a psychiatrist in my office. So when I moved over and it just had a different name and it looks a little different, but it's honestly not that much different. And so that's where I think this conversation was, when it started, was so helpful for me, because I was like, but wait a minute. It doesn't seem like there's a hard line. I'm so confused, and hearing other people go, it's because they're not. And this is blurred, and it's not a stark contrast. And yet in the literature out there in the world, you'll find, I like the idea of an integrated care agnostic. You'll find zealots. But really it is this blend, and then that's really what we've been working here at my organization to say, okay, so what pieces of what do we have where and which with population? And so it is a little collaborative care, but more PCBH leaning in pediatrics. And then on the adult side, there are pieces of PCBH with the warm handoffs and some of the briefer work, but is more collaborative care with the registry, and they meet with the PCs every week and things like that. So it is this kind of interesting blend.
No, well, I think that that's such an interesting point, because it just makes me think, not to be a negative Nancy on the last couple of minutes here, but I think one of the challenges is that the models are kind of, the pros and cons are two sides of the same coin, in that one of the barriers to implementing CoCM we've seen is that people do view it as restrictive because there is kind of that standard, whereas PCBH, you can make it a little bit more malleable because there isn't that like billing code requirement, where it's like you have to have a registry and you have to have a psychiatric consultant that reviews patient cases on a monthly basis, and that you meet with them every week, and that you can only treat people that have a diagnosis that you can code and have an ICD-10 code attached to it. And so that is definitely a challenge, but at the same time, it allows you to fit into a very clear reimbursement model to build those codes. So it's like, it is really hard for some places to do that. And so some places say like, yeah, well, we just don't have the capacity. And a lot of people were talking about that, to have somebody do that additional documentation in the registry, or we can't find a psychiatrist to provide that consultation time. We're just going to kind of do the integrated care with our primary care team. And those things are prohibitive to them to get into that CoCM model. So it is really interesting to kind of think about that, to also hear about sites that are kind of officially on the books PCBH, but are doing a lot of those pieces that people often find challenging about the CoCM model. So I just found your comments interesting. Thank you for that.
So I know we're coming up on, I think, the top of the hour here. We're just hitting it right now. I mean, I really think that there's potential for a part 2 to this dialogue. I really do. I mean, there's just so many great points that have been brought up, and there's really a lot of great contributions that have been made. And I just want to take a minute to honor that and acknowledge that. We've really covered a lot of really important topics today, and I've tried my best to stay on the chat and kind of hit on some of the themes that we've seen. But this may very well be a continued conversation in the future, addressing some more of this, especially as this work continues to evolve. So again, I really want to thank everybody for attending today. I know myself, like, I learned a lot. This has been really, really beneficial, and I hope for a lot of you this has really maybe expanded your mind in a way that, okay, I wasn't really comfortable with CoCM, or I wasn't, super knowledgeable about PCBH, but I took something away from it today, and that's really the biggest thing we aim for with this. I also want to thank the super contributors as well. I really appreciate y'all speaking up. Eric, Allison, Noel, Cody. I really enjoyed getting y'all's point of views as well. And just, the last thing I want to say too is that, everyone who had questions, comments. I mean, again, this is really about you all. This is really about having these dialogues around topics that sometimes may make us a little uncomfortable, or just maybe something we don't know and we want to learn more about. And just to answer some questions too, this recording should be available in about a week. But again, thank you all for attending. Thank you to our contributors, and I look forward to seeing how this continues to evolve.